Hey, so what's up, guys? Welcome back to another session of this lecture series. And a topic for today's discussion is going to be migraine and related drugs. We'll be also talking about serotonin and ergot alkaloids to an extent when we will be discussing about migraine. So, to start with, migraine is a kind of headache. It's a type of a headache, basically a unilateral headache that comes with aura or without aura and has a lot of disability factors which affect the quality of life of a person when the attack comes in. There are various theories which are proposed for why migraine should occur, kind of unilateral headache. The first of that theory is shunting of blood in the carotid atriovascular anastomosis that causes cerebral ischemia. So it's kind of a diversion of the blood towards more of the periphery rather than to the brain itself, and that what causes cerebral ischemia, later on giving rise to neuronal inflammation, vasodilatation of the cerebral arteries, and brings about pain. So that's one theory to start with. The next theory is kind of a theory which proposes spreading of depression in the entire CNS. So this ultimately brings about vascular inflammation, therefore dilatation, and therefore the pain associated with migraine. Anyway, whatever it might be, ultimately this all leads to neuronal inflammation, which results in dilatation of the vascular tree of the brain, release of various cytokines, and ultimately giving rise to a lot of pain, which in most of the cases is unilateral headache. So headache is also combined to extent with nausea, vomiting, and vertigo when we talk about migraine. Migraine comes with aura or without aura. There can be a few symptoms that can precede the attack in some people. In some people, this may not be the case. So that is what you mean by aura or migraine without aura. Whatever it might be, migraines can be of mild, moderate to severe nature. There is a classification, clinical classification about migraine, which relates to its frequency of how many attacks should come in within a month, how severe the attack should be, and whether it disables life, the quality of life of persons or not. So depending upon that, migraine is classified into mild, moderate, and severe as per the clinical practice goes. Anyway, whatever it might be, at the end of the day, we need to have treatment for migraine, treatment for this unilateral headache and associated symptoms of nausea, vomiting, and vertigo. So the primary endpoints that we need to look at when we treat a person with migraine is pain relief at the end of at least 2 hours. So that is our goal. When you want to treat a person of migraine, pain should be relieved at the end of 2 hours. There should be no recurrence of the symptoms in the next 24 hours. So that's also becomes our priority, and drug efficacy should be for at least 2 to 3 attacks. So it shouldn't be that I just take one kind of a drug now and there's a recurrence. No, it should provide some kind of a help in preventing the attacks, at least 2 to 3 attacks in the coming months or so when we want to treat migraine. So those becomes kind of an end point, our goals of therapy when we want to treat migraine. Anyway, somebody comes to you in your clinical practice with migraine or with headache, you want to treat the person with a non-steroidal anti-inflammatory drug, or also called as painkiller drugs. So now we will be having separate session on these topics when we will be talking of pain clinics. I need not go into details of these drugs, but just for your knowledge, these are all the drugs which are also called as painkiller drugs or painkiller medications. They help in reducing the pain by blocking the enzyme cyclooxygenase, therefore inhibiting the synthesis of a cytokine called as prostaglandins, which help in inflammation. So that's the pathway. Inhibit cyclooxygenase, inhibits the enzyme prostaglandin synthesis, and therefore blocking the inflammatory pathway. So we have acetyl salicylic acid, aspirin, 625 to 1000 milligrams. You can also have in your list ibuprofen, 200 to 400 milligrams. You can also have paracetamol. In fact, paracetamol can be one of the best agents because it is gastroprotective. It doesn't cause a lot of gastric problems in individuals. So I should have that in my P drug list. 1000 milligram tablet should be okay, either oral or even suppository, because people will be having nausea and vomiting. So paracetamol is available as suppository, that is rectal dosage form. So that can be one of the ways of administrating paracetamol in these individuals. Of course, diclofenac 50 to 100 milligrams can also be in your P group of agents. You can combine, in fact, the best mode would be to combine ASA, that is acetyl salicylic acid or aspirin, with paracetamol, and you need to add caffeine because that helps in absorption. Now we'll come to all these factors of why caffeine should be added and so on, but just for now note that a combination of ASA, that is aspirin, acetyl salicylic acid plus paracetamol plus caffeine can be one of the good agents for treatment of at least mild to moderate migraine. I'm talking again in terms of mild to moderate migraine. You can always safely start your treatment with analgesic, that is a painkiller drug, a non-steroidal anti-inflammatory drug, and these are all the drugs with the dosage forms, with the doses in, that you can try with your patients and should be all okay. Of course, there's a lot of nausea and vomiting, and there's gastric stasis which is associated with migraine. So you want to try giving these drugs also, which are antiemetic drugs. Now if you are new to this lecture series, you can watch my videos on antiemetic drugs, which will give you a fair idea about these drugs. These are dopamine antagonist drug or dopamine inhibitor drugs, which help in blocking the D2 receptors in the periphery as well as in the center. Domperidone 20 milligrams oral is a good drug, but then again the problem is people might have a lot of nausea and vomiting, so giving it orally may not be that effective. Metoclopramide 10 milligrams or 20 milligrams is available as injectable form or is available as tablet form. Maybe I select injectable form as the person is having a lot of nausea and vomiting, so try with metoclopramide. But then again remember that it also blocks dopamine receptor in the CNS, so can give rise to extrapyramidal side effect. That might be a limiting kind of I should say the limiting factor when you talk of metoclopramide. So that goes against the use of metoclopramide. So domperidone becomes more of I should say a drug of choice, less extrapyramidal side effect as it doesn't cross the blood-brain barrier and does not inhibit the dopamine receptors in the center. So less extrapyramidal side effects. Anyway, you can try either giving it orally, or metoclopramide can always be given by injectable route, IV route, or an intramuscular route is what you prefer. So your primary treatment when you talk of mild to moderate, again I'm stressing mild to moderate migraine, will be an analgesic drug. The drugs are mentioned here, plus you also need to give an anti-emetic drug. Drugs will stop vomiting. So these two drugs go hand in hand when you want to treat mild to moderate migraine attack for a person. Now there are few drugs which are grouped under the banner of 5-HT, 1B, 1D agonist drug. Now what is that 5-HT? It's serotonin. 1B and 1D are receptors for serotonin, type of receptors for serotonin, and these are agonists. So these are in fact serotonin agonist drugs at the receptor level of 1B and 1D. So what they do, they block the shunt. So shunt was a problem because the blood was getting diverted into more of the periphery. So they close this shunt. They cause vasoconstriction of the dilated vessels, because ultimately it's vasodilatation of the cranial vessels that causes pain. So they close shunt, they vasoconstrict the dilated vessels, they reduce neuronal inflammation, Rebound headache is the limitation of its use. So it can give rise to rebound headache once you give this drug, but need not be worrying because these are one of the drug of choice for moderate to severe migraine. Ischemic heart disease, high blood pressure, pregnancy and epilepsy are relative contraindications for the use of migraine because serotonin itself is a vasoconstrictor drug. So don't expect it to be given safely for patients of at least high blood pressure or in chest pain. So that these are limitations when you use a serotonin agonist drug like sumatriptan. So sumatriptan is an example of this group. So subcutaneously 6 milligrams, or if you want to give it by tablet form, 50 to 100 milligrams is what you want to give. You can wait for 1 or 2 hours till the attack subsides. It is fast in action. It is metabolized in liver by an enzyme called as MAO-A enzyme. So that's important because this enzyme also metabolizes other catecholamines, and there are few interactions, drug interactions, that will go hand in hand when you talk of MAO-A enzyme as a enzyme that metabolizes serotonin. So a MAO inhibitor, don't give it to these patients because then there would be a lot of interactions and levels of serotonin might go up and might cause problems to the individual. They interact with other antidepressants also. So MAO inhibitors are one, but there are few other antidepressants which can have the same kind of effect. There are few other triptans, like this is sumatriptan, like one example. There are few other triptans which are more potent and which are longer acting than sumatriptan. So you can always try with these agents. So these are gold standard agents when we talk of moderate to severe migraine. They are very helpful in bringing down the pain related and symptoms related to migraine for these individuals. The next in the class are the drugs which are called as ergotamine or dihydroergotamine, that is DHE, dihydroergotamine. They also cause closing of the shunt. They reduce release of inflammatory cytokines. They cause constrictions of the vessels, cranial vessels, reduces inflammation, low recurrence rate, long migraine attacks with high recurrence. You want to use them. Okay, so people with high recurrence and with long migraine attacks, something which spreads for hours together, you want to use ergotamine or dihydroergotamine. Vomiting, of course, is a major limitation and is slow in action. Of course, you can reduce vomiting by giving dihydroergotamine because you convert it to dihydroergotamine. The property of the drug to cause vomiting goes down. So ergotamine 2 milligram tablet along with analgesic and caffeine to a maximum of 6 milligram. Dihydroergotamine 2 milligram as a suppository. You want to give this to individuals. Now these drugs cause vasoconstriction. So any CVS disorder like IHT, high blood pressure, it's relatively contraindicated. Compounds combined with caffeine analgesics are available. So you have that gold standard in which you have analgesic drug, maybe aspirin or paracetamol. Basically paracetamol plus dihydroergotamine plus caffeine are available. So these agents can be given. But of course these agents are not something which are preferred because of their limitations. You want to use sumatriptan, that is serotonin 1B, 1D agonist drugs even before using ergotamine. So I start up with analgesic drugs for mild to moderate migraine, add an antiemetic drug. If not, if the attack is recurrent, long, or maybe it's severe in nature, I would like to add sumatriptan, that is a 5-HT 1B 1D agonist or serotonin agonist drug. So that is what the treatment is. If not, I will also be adding a last resort, that is ergotamine. So that's how the entire treatment of migraine goes in. For acute attack, you would be using 100 milligrams of IV. Remember, IV acetyl salicylic acid. It's available along with 100 milligrams of glycine nowadays, which increases solubility. You can, of course, in addition, or you can start the treatment with 6 milligrams sumatriptan subcutaneously. Dihydroergotamine can also be given 2 milligrams as suppository. If the attack continues, you want to add 20 milligrams of steroid, that is injection dexamethasone, in status condition. So steroids are used, but you want to use them only if the migraine attack continues in spite of all this treatment. Now these are all the treatments. You want to select one of that. If you ask me, I will be starting with sumatriptan, depending of course on the severity, and it does not help, then maybe add a analgesic drug, and that should mostly work. If not, add a steroid. I won't be using dihydroergotamine, but of course if it's not relieving, it's long, and the attack is long and so on, then of course dihydroergotamine can be of use. Pregnancy and migraine, this can go hand in hand. Paracetamol is a safe drug. Of course I will be trying more with paracetamol rather than any other NSAIDs. I can add sumatriptan 100 milligrams oral in the first trimester. So that is how pregnancy and migraine is treated. For children, domperidone for vomiting. You don't want children to land up in a lot of extrapyramidal side effects. Paracetamol 15 milligrams per kg. You calculate a dose as per the kg. Nasal sprays of sumatriptan are available 5 to 20 milligrams, or zolmitriptan 2.5 to 5 milligrams, and rizatriptan 5 to 10 milligrams were found to be superior to sumatriptan. So you can use a triptan, up to you which one you want to use as per what is locally available. If not, of course antiemetic and analgesic, but analgesic, if I want to use, I will be using more of paracetamol, or the next choice for children would be ibugesic, that is ibuprofen. That is what can go well with children. I won't try with any other drug, as it may not be very safe for children, especially aspirin is not to be given because of its liver toxicity. That was about migraine. Right, so a lot of drugs, but then again this diagram here gives a lot of idea about how you want to use these drugs. Of course you want to, because since migraine is not something which will not recur, it has all the potential to recur. So the best drug for prophylaxis is a beta blocker. That mechanism of how does it act is not well known, but we use a non-selective beta blocker, propranolol. Even you can use metoprolol or even timolol to extent, but P drug for me for prophylaxis, what I will be giving is propranolol 40 milligrams to 240 milligrams. Now 240 becomes very high for the individual, 40 to 100 should be all okay. Metoprolol 50 to 200 milligrams can also be a choice with some of the doctors treating migraine prophylaxis. For children and adolescents, instead of adding a beta blocker, you can add a drug called as flunarizine. That's a calcium channel blocker with 5 to 10 milligrams, and that helps wonderfully in that age group. So for kids you can use flunarizine, but for adults, for prophylaxis, propranolol, timolol, or even metoprolol. There are a few other drugs that also can be used. Valproic acid, that's an anticonvulsant, 600 milligrams, or topiramate, that's a glutamate agonist drug. So glutamate is excitatory neurotransmitter, 25 to 100 milligrams, recently added, which can be a drug of choice in adults for chronic migraine and for drug overuse migraine. So these are a few drugs which you can remember as far as prophylaxis of migraine is concerned. So that's a nutshell about all the drugs and where you want to use them when you talk of migraine. So mild to moderate migraine, antiemetics plus analgesic drugs, non-steroidal anti-inflammatory drugs, aspirin or paracetamol or diclofenac or ibugesic can be all okay. If not, you want to try serotonin 1B 1D agonist drug, that is sumatriptan, or the more recent one would be like rizatriptan, which are more potent and long acting. Dihydroergotamine or ergotamine can also be drugs for treatment, but because of their side effects, maybe you reserve them for resistant cases or for people having long attacks of migraine with high recurrence rate. But remember, vomiting is an issue, so don't want to use them in those cases. For prophylaxis, beta blockers are the best. Non-selective ones like propranolol, metoprolol, timolol should be all okay. For kids and adolescents, flunarizine, that is a CCB, that is a calcium channel blocker, is all okay. Recent additions are drugs like anticonvulsants like valproic acid, or glutamate agonist drugs like topiramate, that can be for chronic migraine or for drug overuse migraine. So that's all about migraine treatment is concerned. Now let's go to the main factor that causes migraine and related problems to the person. So we'll be talking of serotonin. So serotonin is a kind of a substance that is found mostly in the GIT. It maintains the peristalsis of the GIT and so on. So it's produced by the enterochromaffin cells, but to extent that is also been found to play a role in platelets, as well as it helps in platelet aggregation and vasoconstriction, as well as it has a role to play even in the brain as far as mood of a person, appetite of a person is concerned. So you talk of serotonin, you talk of 90% of that would be present in the GIT for well maintenance of that organ. The next would be platelets for vasoconstriction, platelet aggregation, and the third would be in the brain for mood, appetite, and so on. So three organs where you want to talk of serotonin as a substance. So it's formed from the tryptophan, and it has a lot of similarities with catecholamines. So it's in fact how it is produced and how it's degraded, what are the enzymes necessary, and so on. They all match with the catecholamines. So serotonin is synthesized from tryptophan. It's taken, there is uptake of serotonin and is stored in the vesicles. So there are active pumps which are required for cells to take up serotonin and store it in the vesicles. So at both these sites, not only taking it inside the cell but also taking it inside the vesicles requires active pump, and you can inhibit this process of uptakes and can bring about therapeutic effects of serotonin in the body. It's degraded by an enzyme called as monoamino oxidase A enzyme. As I told you, it's found in the intestine for maintaining intestinal integrity, in the brain for mood, for appetite, and so many other functions, cognitive functions, memory, so on. In platelets is basically vasoconstriction, platelet aggregation, that the functions are attributed to serotonin. Serotonin acts through its own receptors. Now these receptors are called as serotonin receptors. There are many types of receptor, of course, but we won't be going that deep into all the types and subtypes because it's too complex. We'll keep it to the receptors which are of clinical relevance. So anyway, serotonin receptors are G protein coupled receptors. Again, if you're new to this channel, you want to watch my video on pharmacodynamics where I try to explain how G protein coupled receptors work. So anyway, activation, or once serotonin gets onto the G protein receptor, it either activates or inhibits adenyl cyclase. That in turn helps in either formation or in degradation of cyclic AMP, inositol triphosphate, or diacylglycerol. It can also follow separately another pathway of phospholipase C. Anyway, it also can lead to opening or closing of potassium and calcium channels. So that's something which is very common when you talk of G protein coupled receptors. Anyway, if you're very new to this and you find it complex, you want to watch my video on pharmacodynamics. That will give you all idea about what I'm talking of right now. The physiological effects of serotonin is smooth muscle contraction, let it be vascular or visceral. So GIT, bronchi, whatever it might be, it causes these smooth muscles to contract. Large vessel constrict, that is how it has an effect when you talk of cranial vasodilatation constriction and bringing about a pain relief for the individuals with migraine. But small vessels dilate, so that's one thing that relates to serotonin effects. Bradycardia, apnea, hypotension are few of its effects on the CVS, and it also acts as a neurotransmitter in the brain, and that's why we have so many drugs which are in line with serotonin when you talk of mood disorders and so on. So these are physiological effects in nutshell of serotonin. Now serotonin, as I told you, will act through its receptors. Few of its receptors are 5-HT1, which are mostly concentrated in the brain, and a few drugs that will be acting through these receptors are buspirone, that is an anti-anxiety drug, that is 5-HT1A antagonist. So this 1A becomes a subtype. Okay, 5-HT1, but the subtype is 5-HT1A. Now it's difficult for a person to remember all these receptors. Anyway, a few of these drugs are important, and that's why I try to only deal with these receptors, because these are clinically relevant things when you talk of serotonin. So buspirone, which is a anti-anxiety drug and which acts as a 5-HT1A antagonist. We have sumatriptan. We learned this drug right now, like in the migraine session. So it's a 5-HT1B 1D agonist drug. Again, a 1B 1D agonist, serotonin agonist drug that is useful in migraine. So that's about 5-HT1, which are basically in the brain. If you talk of 5-HT2 receptors, we have most of these receptors are post-junctional. They are present on the smooth muscles, on the platelets, and in the brain to an extent. And a few of drugs that relate to 5-HT2 receptors is ketanserin. I don't know how much of this drug is in use. Very rare drug. It was developed as an antihypertensive and a drug which gave relief for patients with PVD, that is peripheral vascular disease. So this is a 5-HT2A 2C antagonist. So something to deal with 5-HT2 receptor antagonist, ketanserin. Anyway, this drug is no more, I think, in use. I don't know much about this drug. Anyway, you need to keep in mind when you talk of 5-HT2 receptors. We have clozapine, olanzapine. These are all atypical antipsychotic drugs. These are 5-HT2A antagonists. These are antipsychotic drugs, like for refractory schizophrenia with negative symptoms in schizophrenia, you want to give these drugs. So clozapine is one agent which is 5-HT2A antagonist. Again, drugs which relate to 5-HT2 receptors. We have 5-HT3 receptor that is basically present in the brain and the GIT. And the best drugs when you want to talk about 5-HT3 is ondansetron. Again, if you're new to this ondansetron, you won't need to watch my video on antiemetic drugs. So this is antiemetic, anti-vomiting drug. We have granisetron, so many other drugs, potent antiemetic drugs, drugs which are used for chemotherapy induced vomiting and so on. So this is 5-HT3 antagonist at the center, that is at the CNS as well as in the GIT. So it will try to block these receptors in the periphery as well as in the center. Very, very potent antiemetic drugs. And then you have 5-HT4, which are receptors which are present mostly in the GIT. And you have cisapride. Again, newer agents will be mozapride and so on. These are prokinetic agents, drugs which will cause peristalsis to go from top to bottom, so that they drive the fluid from drive the food and the fluid from top to bottom, not top to bottom, from esophagus down onwards to upper GIT. So these drugs are 5-HT4 agonist drugs. So these drugs are the ones which will be using for GERD, gastroesophageal reflux disease and so on. Now cisapride is out from few markets. The mozapride drug is what is in use at this point as a prokinetic agent. Drugs for GERD, that is gastroesophageal reflux disease. We have in general 5-HT blocker. This is a new drug, nothing to relate with one specific receptor. This is called a cyprohepatidine. It's one of the key components of tonics which increase appetite, and in patients who suffer from GIT problems like post dumping syndrome and so on, you want to use cyprohepatidine. But the best use of this 5-HT blocker is for appetite stimulant. It will stimulate the appetite and so on. So that's about cyprohepatidine, a universal serotonin blocker. Anyway, there are few tumors of the GIT in which these are called as carcinoid tumors, in which 5-HT levels in the body increases. So you want to use a few drugs that can be of serotonin antagonist action in patients with carcinoid syndrome. If that was all okay about serotonin, these are all the, I should say, the receptors that you need to know as far as practice is concerned. As I told to you, serotonin is taken up in the cells actively and is taken up within the vesicles also by active pump. So you can block the uptake of serotonin and can increase the levels of serotonin at the synaptic junction. So we have few drugs like SSRIs, that are serotonin reuptake inhibitors, selective serotonin reuptake inhibitors. We have tricyclic antidepressants and reserpine. These are the few drugs that will cause a blockage of this uptake either at the cell membrane level or at the vesicle membrane level. So a few drugs of this class would be SSRIs, tricyclic antidepressants and reserpine. That completes up a full picture on what serotonin is. I hope you got what I said. This is nutshell about serotonin. Of course, there would be pages and pages to write about serotonin, but then what implies and what is a must to remember when you talk of serotonin is what I just informed to you. So if that was about serotonin, the next is ergot alkaloids. Now the word alkaloids, people don't know what it is. It's a substance with a lot of nitrogen atoms in it. So ergot alkaloids. In fact, this word comes from a few poisons which are related to some fungus which grows on grains, especially millets and so on, and which can give rise to kind of dry gangrene in individuals. Very rare to see nowadays. Anyway, so these substances are the ones which will be termed as ergot alkaloids. These drugs have a lot of actions, combined actions, so it's slightly again difficult to remember everything. The two drugs that you need to remember in this class is ergometrine and dihydroergotamine. So these are two drugs is what you need to remember at the end of the day, because they are in practice for a long time. So when you talk of ergotamines, the first action that they have is alpha receptor blocking action. The second, of course, is 5-HT receptor. A few of them are agonist drugs, or some few of them are antagonist drugs. Few of them are partial agonists, partial antagonists to serotonin receptors, and they are dopamine receptor agonist drugs also. If you talk of ergot alkaloids, then two drugs that come in line when you talk of these this group is ergometrine, and ergometrine is alpha action is negative, dopamine agonist action is positive, 5-HT agonist antagonist action is positive. These are all potent emetic drugs. So you give this drug, the patient has feeling of nausea and vomiting. Ergometrine, the gold standard use of ergometrine maleate is in labor, that is after the labor. You do not want to give it before the labor because the uterus contracts, and you want to use also in postpartum hemorrhage. So these are two big uses of ergometrine maleate. So you want to use them for this after the delivery, so that there is no much bleeding, or in cases of postpartum hemorrhage. Never to give this drug before the labor starts or within the stages of labor. Okay, the next drug is dihydroergotamine. Now that dihydro reaction itself brings down a lot of side effects of these drugs. Okay, so it brings down the incidence of a lot of side effects. These drugs loses most of its potencies to cause side effect. So alpha action is weak, emit action is weak, contraction of action on the uterus is also weak. Dihydroergotamine is basically used in treatment of migraine, and I already informed you how it causes that. Reduces inflammation, reduces shunts, causes vasoconstriction of the cerebral vessels, and so on. So those are actions which are attributed to dihydroergotamine. Some groups also use ergotamine, but then ergotamine becomes more toxic, so better to use dihydroergotamine plus analgesic like aspirin or paracetamol plus caffeine. Now that works and is used by a few for treatment of mild to moderate migraine. Anyway, if you talk of these two drugs, then they are incompletely absorbed through the GIT. They are metabolized in the liver and are available as tablets and injections. Most of these drugs cause nausea and vomiting, and since I said to you they have the potency to cause dry gangrene, so they can cause vasoconstriction. Now that becomes one of the few limiting factors. Now since it causes vasoconstriction, need not be given to patients with high blood pressure, patients with ischemic heart disease, any other vascular problem, PVD. Better try to avoid this agent. So that was again in nutshell about ergot alkaloids. Only just two drugs described, and that should be enough as far as practice is concerned with ergot alkaloids. Now that was all about migraine, serotonin and ergot alkaloids. That is, these are two substances which relate to migraine on a closer angle. So I just thought it is better for me to describe it now rather than describing it in some other session. So I hope you like this session. Thank you, and stay tuned and do subscribe. Bye for now.